All right, we're going to get started, even though people will be drifting in. So welcome to today's presentation. This is part of a series that we have called the Elena and Zaremski Law Medicine Forums, which were endowed by a 1975 alumnus, Miles Zaremski, and his wife. We have a couple of these every semester, and if you're not getting information about them and would like to, please leave your name with Nancy Pratt outside, and we'll be sure to keep you posted on forthcoming items of interest. Today's panel actually grew out of an invitation to Richard Besser, the senior medical correspondent for ABC News, formerly of the CDC, to give our another lecture series that we have, the Schroeder Lecture, honoring the founder of our Law Medicine Center, Ollie Schroeder. And we had asked Dr. Besser to do this, and he had committed, almost a year ago. And was supposed to do it in early November 5th, and about 8 days earlier, he contacted us and said, I just got back from covering the Ebola crisis in Liberia and thought you ought to know, because I'm going to show up in a week to your to give this talk. And we deliberated about it and ended up just for the sake of the comfort level of the people in the audience who would come and hear this, inviting him to do it by video, Skype, which he declined to do, and published an op-ed about it in the Washington Post, which you may have seen, in which he complained about the overreaction of this university to the danger, and also to the concerns of some of his children's playmates' parents who didn't want his children to play with them for a while. But he was very pleased at the number of co-workers who came up and gave him a group hug when he returned to his office at ABC. And that led us to, so in lieu of that presentation, we thought we would bring together three of the most expert people in the Ebola crisis, in how this crisis might be managed by public health officials, and the legal and ethical considerations that underlie the public's response. And so today we have three speakers. The first is Jim Kazura, a physician who is one of our newest distinguished university professors. He's the director of the Center for Global Health and Diseases at the School of Medicine here at Case Western Reserve University. He specializes in preventing and treating infectious diseases in ways that are both culturally appropriate and resource conscious. Our second presenter is Scott Frank, also a physician. He is an educator, a researcher, a practitioner in public health and family medicine. He's the founder and current director of the Masters in Public Health program here at the School of Medicine. He is also the director of the Shaker Heights Public Health Department, a practicing family doctor, and also a principal investigator of the Research Association for Public Health Improvement, which is Ohio's public health practice-based research network. And last but not least, our own interim dean, Jessica Berg, the Tom J. E. and Benny Lou Walker Professor of Law, also Professor of Bioethics, also Professor of Public Health, who during a sabbatical in 2009, rather than sitting on the beach as the rest of us do reading novels, chose to complete a Master's in Public Health degree at the School of Medicine. So they will be presenting, and we'll begin with Jim, who will give us an overview of the medical perspective and the international perspective, and then move on. So thank you very much, and thank you all for coming.
So first of all, let me declare I am not an Ebola expert, and that's one of the problems that we're facing collectively. There aren't many Ebola experts because it's not been examined in any kind of serious way. And this epidemic that people are now experiencing in West Africa is really the first of its kind. It's not studied in many ways. First of all, because it's not a public health problem outside very poor areas of Africa. That's number one. So there's not a lot of resources that go to it. Secondly, it's a BSL-4 biological agent that it's strictly under high containment facilities, especially in the aftermath of 9/11. It's very, there's about 2 or 3 places in the country that can actually work with the real virus. That's Fort Detrick in Maryland, the University of Texas Galveston branch that has BSL facilities, a facility at the CDC, and there's a primate facility in Texas where people are also, and near San Antonio, where people are allowed to work with it. So this virus was first discovered. It could have been around presumably for thousands of years in some remote areas of Central Africa in 1976. I won't go through that history, but that's when the virus was first isolated and people got identified the etiologic agent. The means of transmission of the virus, presumably the virus, and this is still not absolutely clear, it's thought to be endemic in some fruit bat populations in Central and West Africa. That's presumably how it makes its jump to humans and other primates. Ebola has been a major killer of Eastern African gorillas in parts of Gabon and the Democratic Republic, and especially when due to these kind of situations, it appears to have actually reduced some of the gorilla populations in that part of Africa by 40 to 50%. So between 1976 and up until the present time, there have been periodic small epidemics in remote areas of Central Africa where there was Ebola virus infection. The mode of infection, presumably what occurs between the bats and the humans, we don't really know for sure, but bats chew fruit. They have hollow bones, they're flying mammals. And so the saliva of the bats is presumably thought to contain the virus, and someone picks up some fruit and eats the fruit that a bat had previously had partially tried to eat, and or bats are common bushmeat in Africa. I work in New Guinea as well. Bats are common bushmeat in that and many other parts of the world where there's large flying bat populations. So that's presumably how we incur ourselves, or humans populations, go to areas where they previously had not been, and you get these kind of interactions. And then the human-to-human transmission only occurs with close personal contact. We've all heard of the 21-day rule. There is no evidence at all that there's any aerosolization, that sneezing or coughing can lead to transmission, which distinguishes this hemorrhagic fever virus from other hemorrhagic fever viruses where aerosolization is possible. One of the reasons that this agent is the BSL-4 facility is it could potentially be weaponized to do such a thing. And this is something why research on the virus has actually been relatively limited because, again, as I mentioned, because of the containment requirements and regulatory issues in that respect. We don't know exactly how this epidemic got started. It presumed started in Guinea when a 2-year-old child died of this and was near other people. And it took several months for the WHO, the CDC, and the international health community to really get on track to see that this was something that appeared to be distinct from what we've seen in the past. For the purpose of today's talk, I'm only talking about the West Africa issue at the present time, but as of this morning when I looked this up, there's been a total, as of November the 5th, of 13,042 cases in West Africa. This is predominantly in Guinea, Liberia, and Sierra Leone, with 4,818 deaths. This is presumably a really underestimate. These are some of the poorest countries in the world. Most people estimate, they use this for modeling procedures, that the number of cases and deaths probably is at least double that. There's been some recent reports that there may be cases that are decreasing in some parts of Monrovia. I think that remains to be seen. We had a meeting last week at the American Society of Tropical Medicine and Hygiene, which is one of the major groups in the world that meets around tropical infectious diseases, and Ebola was on the top of our list. Germane to today's meeting, all of us, I've been president of that society 2 years ago, and I was editor of its journal for about 14 years. We all got a letter for anyone who was attending the meeting, who had been in any of the Ebola epidemic countries within the last 21 days, whether you're sick or not, is that you would be quarantined in your hotel room. And this was by Bobby Jindal, who made the executive decision as the governor of Louisiana. We met with public health officials. They recommended against this kind of thing, but obviously that was the governor's decision, and I think that you all probably are much better aware of this than I am. The CDC can make recommendations, but every state can really do what they want to do. And we saw that in the politicization of the process when Chris Christie had certain rules, blah, blah, blah. We can discuss that later during the discussion. So at the present time, there's no evidence, at least as far as I can tell, that the epidemic is subsiding. And many people believe it should continue for the foreseeable future for the next 6 to 8 months. As we all know from reading the newspapers, quarantine is a major issue with this. In Africa, quarantine is very difficult to track because of the number of contacts that people have and where they live in communities, especially in places. And one distinction here is that we're seeing this epidemic in highly urbanized areas, which in the past has only been in rural areas. So there may have been enough containment possible in these more isolated, small population sizes. There were cases in Senegal, Nigeria, and most recently in Mali. Those countries now, with not only with their own public health infrastructure, as well as with the CDC and some consultants from the World Health Organization, have apparently stopped the epidemic in those areas, largely by quarantine-type procedures, including the one in Mali, where there was like 1,200 or 1,000 contacts of that 2-year-old girl who was actually had a bleeding nose as she was going from Guinea through up to north central Mali. So that's a remarkable feat. And apparently the CDC people, along with the Malian Public Health Service, really got on top of this. So that is now declared Ebola-free. So the case fatality rate now, depending on where you look, is anywhere from 40 to 80%. It's much lower in the few cases that have occurred on people who had acquired it there and then went to Europe or the United States, or the several cases here where there was secondary contact with healthcare workers that they acquired the infection actually in hospital. For example, from the man from Liberia who died in Dallas a few weeks ago. There is no specific antiviral treatment known for this infection. It appears that from the time of exposure, and this is probably best documented in the case of healthcare workers, where you know you have the types of contact you have with people and with their bodily fluids, is around 6 days after the inoculation occurs is when clinical manifestations occur. Initially, it's a viral kind of flu-like symptoms, and then it quickly transfers. It was historically a viral hemorrhagic fever, and they called that the hot Ebola. And some of the people at this meeting last week who had been there actually in 1976 and stuff, you can see there was a lot of bleeding. This appears to be the major reason that people presumably die from this, are because of electrolyte imbalance and dehydration. It's not uncommon that people have diarrhea where they lose 5 to 10 liters of fluid through diarrhea per day. And at the stage when they're that ill with this, there's billions of virions in the body secretions of these people, in mucus, in stool, in sweat, things of that nature. There was discussions at the meeting that I was at last week about where we are in terms of, we've all heard that there's various monoclonal antibodies that have been developed against this, and in some of the primate models, they appear to be protective, at least if you give the animal the monoclonal antibody shortly after deliberate inoculation with the virus. It's obviously not going to work to prevent anything because there's not enough just to go around. There's really not enough for treatment. But I must say, there is no clear evidence that that is what has saved these people's lives. But I think the consensus would be, for example, in these first 2 patients who came from Liberia and then they were at Emory University, was probably meticulous electrolyte balance and close hydration. If they needed renal dialysis, they had kidney failure, that was available to them. The essential only treatment that people get in Africa now is you have these people come here, like the physicians and nurses and other healthcare workers, that have appropriate protective wear on. They essentially get a blood sample to do the diagnosis for Ebola, but there is no following of electrolytes, and most of the fluids are given by orally if the person can take it, because even putting in an intravenous needle into someone has a lot of risk for healthcare workers, let alone the facilities. You can only stay in these facilities for 30 minutes because of the heat. Some people there, there's these portable devices you can use for serum sodiums and stuff like that. But I was talking to a guy actually who is working there. This is Dan Bausch. He was here a few weeks ago. None of those devices work in the middle of the afternoon in that part of West Africa. It's 110 degrees. They are made for environments in a room like we're in today. They do not withstand the environmental conditions that are pertinent to where the epidemic is happening. There is a lot of money being thrown at research now. A lot of money to support research on this, both at the basic and at the epidemiological level. There are really, with some of the vaccine candidates that have been tested remotely in primates and stuff like that, there's phase 1 studies that are going on right now in healthy U.S. individuals and Europeans and in Mali to see if some of these, like the vaccine, is actually immunogenic. Do you get an antibody response against that you would anticipate against some of the viral proteins? It's very difficult to see how you would do a valid clinical trial in this situation, but there's no other choice. So what people are talking about now is that with some of the vaccines to actually stop the epidemic, again, this is an unknown whether we'll need this, but at least it'll be helpful for the future if this ever occurs again, is that you have products A, B, and C, and the people that you could try it with, there's several approaches, is that you administer the vaccine to half of healthcare workers and not to the other half of other healthcare workers. Let's say there's a new vaccine now, it passes safety testing, then you just add that onto it. And that'd be one way to do it. It's a case control study. It's the most powerful type of clinical trial to get an answer as quick as you can. There's no one currently contemplating doing a vaccine for prevention of immunities at this point. That may happen in the future, but there's no evidence that that's going to be occurring in the foreseeable future. And one final comment on the other treatment that people have talked about is human serum of people who survived Ebola. We're hearing a lot about that in the news. It's really not clear if that works. Anecdotally, people have talked, they take serum from individuals A, B, and C, and they transfuse it, and then they challenge a macaque monkey with the virus. Sometimes serum from the person who recovered from it, person A, won't do anything, but they combine all three. Sometimes the monkey's protected against it. Just because you have antibodies doesn't mean they'll actually function appropriately. These are the kind of research questions that people are asking going forward to try to deal with the epidemic right now and in the future. So I'll stop there. Is that it?
We'll have time for questions and answers after our speakers. So thank you very much.
For this panel today, I've put together a list of the 10 biggest dilemmas regarding the public health response to Ebola. And when I say the public health response to Ebola, in the U.S., it's to the Ebola threat. In Africa, it's to the Ebola crisis. But some of these principles are oriented towards the U.S. response, U.S. public health response to the Ebola threat. Many of them also would apply in Africa. The first of these dilemmas, Jim actually introduced even in the Africa situation, and that is that under-response tends to lead to over-response. So initially, in the U.S., there was an under-response to the Liberian man who came to the emergency room and was sent home. Now, every other response to someone who has any possibility of exposure tends to be an over-response. The healthcare workers who developed Ebola fit also with the perception of under-response. So over-response follows under-response. As some of you may know, the case definition for any infectious disease tends to evolve through the process of an infectious disease outbreak, an epidemic. And all action is based on that case definition. In this situation, it wasn't even a true case definition of someone with an illness, but it was a case definition of someone with exposure. We had in Sugar Heights someone who was on the plane with a healthcare worker from Dallas. So the first question was she in the hot zone, the contact zone, which was considered 6 feet anywhere around her? And it turned out he was one row behind that. So, is that really a difference? Was he exposed to her at an earlier time? Were they in line together? Any of those questions were coming to mind. But as it became clearer and clearer, the level of risk that was posed by the healthcare worker didn't really require the level of action that subsequently took place. But that case definition changed from just being on the plane with her to only having physical contact with her as the highest risk, and that just presence on the plane with her being a very low risk. That's not the way it started. That's not the way it started. I also had the under-response. CDC also had an under-response to the Dallas situation in terms of not sending the sorts of personnel to the site that were advisable early enough. And those under-responses also create trust issues with the public between Dallas Hospital and the public, between the CDC and the public, and make everybody's process more difficult. The next of our dilemmas is that fear is more contagious than Ebola. It is often as dangerous, and mixed messages are a vector for fear. Examples of mixed messages include unnecessarily closing schools or canceling events like lectures at the law school, and doing so in the face of minor exposures to the disease. I'll add to this dilemma that when politicians make decisions, messages become mixed. The decision made in Louisiana was a clear mixed message that fed public fear and was not in any medical sense or public health sense indicated restriction or quarantine. I'll also add that politicians are really only in charge when it matters. If there were a true Ebola outbreak or pandemic flu outbreak, the decisions really would be made by the public health officials working with medical officials, working with the government and politicians, but the decisions, when it really matters, do get made by experts rather than politicians. Our job is to keep politicians quiet, in fact. My next point is while Ebola is not as easily spread as many infectious diseases, as Jim said, the number of healthcare workers who developed Ebola gave the appearance that it was more easily transmitted, again, feeding fears. And even though these healthcare workers were generally properly protected, they were exposed to body fluids that the rest of us weren't. But it seemed like it was casual contact or contact even though they had super suits on. And the issue probably was one of those anticipated events. They were very careful putting the protective equipment off, but not as cautious in what we call doffing or taking off the protective equipment, where most of healthcare worker infections in fact happen. All right, next my points is that while Ebola cannot be spread until symptoms develop, which is a real advantage to the healthcare system and relatively unusual advantage, people recognize or perceive the onset of symptoms differently. So though it doesn't happen until the symptoms do, diseases do present atypically. Fever may not be the first sign. People perceive their symptoms either through a lens of hypervigilance or a lens of denial. And if they're seeing it through a lens of denial, they may in fact have symptoms and be contagious before they identify themselves as such. My sixth point, there are nearly an infinite number of details that you do not anticipate until an emergency event occurs. We do a lot of planning, of drilling, of practicing, but as many contingencies as we think of in public health prior to an emergency event, there are many more details that occur that didn't occur sufficiently to the group to prevent problems. That donning and doffing issue is one of those. We needed to find a way to include funeral directors as we had our meetings with or about Ebola, because how to handle bodies if bodies in fact became prevalent was an issue. So lots of these details that we have to have on our mind. My next principle is that the number of people who need detailed ongoing updates in a true public health emergency is exponentially higher than you think it is. The corollary of that is that the number of people who think they need detailed ongoing updates in a true public health emergency is exponentially higher than those who actually need that information. So communication becomes a real problem. My corollary to that is that the ability of conference call technology is both a blessing and a curse. My eighth principle is that in the midst of a true emergency, response will consume as much time as is available. All of us who were involved in any way in the Ebola threat just had our time stolen from us in ways that we couldn't have anticipated. The ninth principle is that all public health emergency response is ultimately local. This is a principle that's been espoused about emergency response in many different ways, and again demonstrated in this situation. I'll add to this that in the situation of Ebola, at this point in history, virtually all solutions to the Ebola crisis in Africa and threat here in the US are public health solutions, not medical solutions. There are efforts to make medicine a more important component of how we respond to Ebola. But at this point in history, anything that's effective is basically a public health solution, other than hydration that Jim talked about earlier. We do get support from state or national support sources, but the application of the support is really what defines the effectiveness of the incident management, and it is, again, that local planning, meeting, drilling, talking about emergency response, any emergency response that renders a more effective response to any emergency event. I will say that in Northeast Ohio, I have very positive feelings about the way the public health system responded to the threat of Ebola in our area, and the level of communication between public health agencies, within the public health agencies, and beyond from the public health beyond, I think was just about as good as it could have been done. And my last point is that the US-centric response of the American public to this Ebola crisis is simultaneously understanding and disappointing. The importance of the Ebola threat in the US is really dwarfed by what's happening in Africa. There may have been a lift up in efforts or funding to address the African issue, but as I say, both understandable and disappointing. So thank you for your attention, and
And I'll look forward to your introduction.
Okay, I don't want to spend too much time because I want to leave most of our time for questions. One of the ways to think about the ethical responsibilities is to walk yourself through the different levels that you might consider. So if we think about the individual responsibilities, think about institutional responsibilities, think about, say, professional responsibilities more generally across the profession, move up to sort of the government level, state, think about our responsibilities as a nation, and then think about our responsibilities as an international society. When we think about these things, a couple things have struck me, and maybe this is somewhat along the lines of Dr. Frank's list of kind of things that you watch happening and realize where there's some disconnect. So the first on the individual level. One of the things that has been suggested in a variety of settings is our individual responsibilities to make various choices about what you do, where you go, who you expose, whether you should travel or not. And there were certainly a lot of suggestions by a number of prominent commentators, both law and in ethics, who have suggested that if you were exposed at all, you should deliberately on your own make decisions not to get on an airplane. If you were anywhere at risk, you should use social distancing techniques. What I think was most striking about this sort of debate and discussion, leaving aside for the moment some of the limitations we have at an institutional level, for example, would that mean that you were going to get fired from work? Could you actually take the time off? What would happen to your kids? Could you feed anybody in your house? Ignoring those kinds of problems there was the complete absence of a discussion about how important at this time of year and for the next few months, some of these techniques are and should be used for flu. Right? And we sort of left aside the fact that in fact we have a very rich understanding about how to use various public health measures as an individual and maintain our distance. And so, for example, as Professor Mehlman pointed out, I found it extraordinarily striking that Dr. Besser's discussion about how wonderful it was that everyone hugged him ignored the fact that at this time of year, it's probably not the best idea to be hugging a whole bunch of people, because there may be people you normally come in close contact with. So just this idea that we've completely separated out this from what is a much more significant public health and maybe even individual responsibility in thinking about what we should do in this context. As we move sort of to the next level from the individual to the institution, there are additional questions about what are obligations of institutions to make sure, for example, if someone chooses an individual, or you think that you want to maintain social distancing, to provide adequate sick leaves, right? We know this is a fundamental problem for lots of different things that spread at this time of year, because we hear from people who say, I have 3 days, right? It's not going to help me a lot, so which means I'm still going back when I'm still, shedding virus in not the Ebola context, we'll certainly guess there too, but, in the more common context of everything else that you come down with, right? So you show up there, the kids who show up for school, and the school keeps saying 24 hours without fever, without, vomiting, and the parents say, but I can't stay home from work. So my kid looked okay this morning. Yeah, I kind of was expecting they'd call me midday at the point where they've, exposed everybody who's around. So how have we really set up our institutional responses at all to deal with some of these things? Another interesting question has always been, what if you did need to use a quarantine in a setting like this? And I ask my students this sometimes when I do my public health class or public health ethics, and I say, well, I'm curious, how would you know? Would you just kind of walk out of the classroom and find that the doors were barred? And if so, what about the people that just walked out right before we barred the door? A couple of my students said, well, we've used one of these, kind of messaging systems. Campus has them, that's great. And I point out that I'm hoping you're not on your cell phone in the middle of class. So, you probably wouldn't get the data right away, right? We have a real serious, let's go back to Dr. Frank's point. How do we communicate any of these things? We very rarely thought through all of the actual practical implications of using any of these things in any kind of an institutional setting. One of the things that the university struggled with was, how do we understand obligations for organizations like universities or schools, knowing that fear travels much faster than most of the viruses, and worried about the implications for people who would then voluntarily stop coming to classes or stop coming to school, or whose parents would sort of hit the roof and thinking, oh my gosh, you had a speaker here that was doing X, Y, or Z. Are those responsibilities that organizations have to think through and then respond to it. Obviously, the university made this decision at the highest levels in terms of how they were going to handle this. They felt that the best response was to do this using video technology. And certainly that was a way to respond. They certainly struggled with, were they meeting their responsibilities from the perspective of their responsibilities to the students and the population, or were they undermining responsibilities to make sure that they were adequately reflecting whether it's a real risk or not a real risk? And those are things I think we constantly play around with in a wide variety of settings. Professional level responses. So we've talked a lot, or heard a lot, at least in the press, about whether professionals have a responsibility to go and help and provide care. And of course, talked also about what are the implications of if you do that for when you come back into this country and some other constraints that you might see. What kinds of obligations do professions have? One of the most interesting things that we have found when we do a lot of these tabletop exercises and ask about what if something would happen, it shows us very clearly the gaps. Communication is absolutely one of the biggest gaps. One of the other gaps that we see consistently is that we have forgotten certain groups of a profession. So what did we forget here? Well, who's going to collect the garbage and how are you going to handle them, right? Who's going to deal with the bodies once if you do have bodies and need to dispose of them? Who's going to handle the food deliveries or anything else? So very early on efforts to think about, say, pandemic events in a hospital setting, we ran the exercise and everybody thought through things, and the police were on board, and the nurses were there, and the physicians were there, and the techs were there, and everything else, and the people who did the food service and the laundry didn't show up. And what happens then? Within a couple of days, you shut down. You have no mechanism to keep your institution running. So the parts of the things that we have not quite clicked in and months it should be. So some of these are the same kind of debates that you have. One of the biggest ones consistently is, right, Dr. Frank's right, yes, in fact, the government officials, the politicians really aren't supposed to become involved until, it's not really a public health issue. It's supposed to be, if it really is, you have other people driving the bus. Well, the problem is, of course, is what you really want is the expertise driving the bus early on. So you don't have somebody coming in and saying, well, now everybody needs to be sitting in their hotel room for 21 days. And oops, we haven't really figured out how we're going to manage to keep everybody there and provide them all the services. So we also have this sort of disconnect. Yes, if it's truly an emergency, public health officials do get a lot of power and get to step up and drive things, but it could be that maybe they should be doing that very early on, or at the very least, they should have a role at the table having the discussion so that you don't get such a disconnect between the two sides of things. National level questions about, we have headlines that came out yesterday, it's over. Everybody breathes a sigh of relief. Well, it's not over for the world. It's certainly not over for a number of people who will travel back and forth. It's not over in the sense that we've actually accomplished anything by, say, curing it, finding a vaccine for it, or some guarantee that you cannot get anything here. So what are our continued obligations as a nation to be acting in this area? One of the most interesting things has been this question about research. How can you do research? Suggestions about whether or not you could or could not, say, use placebo-controlled trials in these contexts. How do you understand the use of things that you may not have a good answer to about whether or not it works? And if you don't have an answer to whether or not it works, are we justified in giving it to anybody? How do we actually get the data that we need? Those are usually very, very difficult questions to answer, especially in areas where we don't have a lot of the background. And then obviously as a world society, it highlights for us, I think, again, how different we are around the world in the level of care we receive. We don't like to think in those terms, but it's been fairly obvious, at least in this case and in many others. This one got a lot of high-level attention because it was so striking, the difference in the mortality rate. If you were treated one place versus another place. The level of care that we provide around this country varies enormously, around the world varies phenomenally. And in a world that truly doesn't have borders that diseases are willing to recognize, right? They are happy to come over any border that's out there. What does that mean for our responsibility more broadly, internationally, about what we need to be doing in this context? So I'm going to leave it at that just so we have enough time for questions, and I think the idea is that everybody comes to answer questions.
Yes.
30 years ago, we didn't have the internet, we didn't have email, and it just seems like nowadays it must be easier for you to do all the communication. But did the internet really make it worse? I mean, 30 years ago, would we have had less panic because we only had radio and TV?
You know, if you follow the sort of Orson Welles saga, radio alone can cause a lot of panic. I do think there's an element of information traveling faster than we can sometimes even keep up with what we're reading out there. And actually, there's some very interesting studies now about people have very different ideas about what they believe that is on the internet versus in print. And we're actually, you know, one way to think about this is, well, people are really gaining the notion that in fact, if it's on the internet, it may not be real, but if it in print, it is real. You actually get a very strange effect, which is people will read something printed and forget that in fact, there can be flaws there too. So they will look at it in print and actually think, well, this has to be true because somebody bothered to print it out. There's also a strange effect where people will say, well, I don't believe everything that's on the internet, but the truth is the more you see it, we do know the more that an idea kind of becomes embedded. So if internet stuff, and we know is that information flows out and people get it multiple times. So it kind of circles back to you. And it can be the same false information, but the fact that you've seen it so many times and the internet can make that so quick is a difficulty that we have to face. So it's made things easier in some sense, it's made things more complicated in other senses.
It's given us a different metric that we've never had before. We've been able to do Ebola mapping in terms of tweets or internet comment coverage on Ebola, and it really is interesting to see the huge spike during the initiation of the threat, and then to see it calm down over time. It's really calm now, despite the fact that the main nurse in the New York case are present. The spike was in that initial period of time, not so much prolonged. So that smaller attention span may have some benefits.
I just want to add two things. First of all, like 3 weeks ago when Dan Bausch was here, he gave some interviews and the media came here, and then I did some interviews, which I've done this before, but it was on Fox News and with another television channel. And particularly with one of the channels, you might guess which one this is, that I'm going to tell you about, is that, so what you do is you go up there, they have your picture on TV for a minute, and then there's hundreds of emails or blogs coming in. And so first of all, again, from that perspective, so this is the general public. But some of the questions are quite valid. Some of the questions are just way out there and stuff like that. But I felt my job was to tell the facts as I knew them and to kind of dim this smother this fire a bit. But then they would patch back to the people that were preceding Dick Goddard to talk about the pets. Okay, none of the pets here at Ebola. We didn't even know the dogs here. But the people on the news just fan the flames again. So it's part of so news now has become more entertaining. Part of that is the internet, but it's not. And I remember earlier in my training, I was training swine flu. Some of you were probably not born at that time yet. Certainly I wasn't, but I was a house officer, and there were some people who died after they got the vaccine. And as it turns out, it was actually the vaccine was contaminated with stuff. But that was really, I would generalize that to go beyond. I think there's a general mistrust of science in this country. And people don't want to hear something and don't believe in it. I'm not saying this from a political perspective because this cuts across a lot in stuff. And I think that at least when I grew up, and that was in the 50s and 60s as a child, that there was, in general, at least speaking as if I can reflect back what it was like, is that I generally believed what I heard, but it was presented in a more dispassionate way than it is now. It's less polarized than it is now. And this conference could be about global warming, whether you believe it or not believe it, or stuff like that. So what, like Richard Besser, I did, and one of the things on his blog, as I call it his blog and everything, was people have a greater chance of dying when they're texting on their SUV as they're driving home than of getting Ebola. But people don't think risk is a very, very complicated concept. understand something, even though the risks are higher, then we accept the risk, or we understand what it is, as opposed to Ebola, which can come out of nowhere. I think, and that's something that is a matter of education, but you have to have people, a receptive audience. And I'm not trying to be condescending, but I think because the science isn't all there either. People do not like to hear that is it impossible that Ebola can be transferred by aerosolization? I would never say that's true. Okay? And but there's no evidence that it occurs. And it's not a dichotomous enough response to satisfy or to assuage people's concerns.
A brief comment. I learned 30 years ago when I first learned crisis communication that media, the purpose of media was entertainment. The purpose of public health or medicine is education. So that's not a new concept.
No,
The media has always been more about entertainment than about actual facts and information.
Anybody else?
What would it take for a virus to become airborne, and is that likely? And if it did happen, would transmission rates be different in a colder climate than a warm climate?
Well, aerosolization. So, like if you sneeze, there's blood, and you're having a cough that causes blood to go into the sneeze. Yes, it could be transmitted. There could be virus in there, and there's but it would probably take a mutation in the virus that allows it to actually bind to cells in the airway. This is what the key was with SARS. That's another one that we all have had experience with and stuff like that. And that was really determined during the epidemic. I mean, it was quickly that occurred. It just shows you how advanced the science is. But there's no evidence that any of these mutations have occurred in the Ebola virus. But I can't say it wouldn't occur. There's no reason to believe the replication of these RNA viruses is very inaccurate. There's always mistakes that are made. Because I guess a virus is a living thing, but I just see it's a chemical reaction that it needs a cell to grow in. Okay, it is life, so to speak. But these mistakes are made all the time. But there's no evidence at all that it could probably be done deliberately. I mean, someone could engineer a virus and put in the right protein, and this is what we dealt, and this is the world we live in now. So.
A lot of the response to Ebola in this country had to do with let's quarantine people. Do we know, from a public health standpoint, how effective quarantine is either in general or in certain classes of infections?
Excuse me. So let me just start responding, Jonathan, by saying that I've been in public health, director of the Chicago Heights Health Department for 20 years, and me and anybody that I know in public health has been there longer has never been in the situation of forced or enforced quarantine. This is the first time that's happened, and it did happen in this case. Enforced quarantine is a very unusual event, and whether it actually needed to happen here or not, who knows. I can say that the 50 people in Northeast Ohio who had some level of monitoring required or imposed upon them were tremendously cooperative in self-monitoring, in some cases self-quarantining, in other cases the lowest risk groups had no restrictions except to monitor their own temperature, and one of the risk groups had to report that on a daily basis, twice a day on a daily basis. Another group was instructed to simply self-monitor and not. So the question of how effective is quarantine? Quarantine's effective. Even self-quarantine, even partial quarantines, the quarantining that is happening in Africa is largely the mechanism by which the infection is decreasing to the extent that it is, and in countries where it was introduced, as Jim mentioned earlier, the quarantining presumably
Historically, worked with smallpox very well.
Yeah.
And, you know, there's papers, we had a grant in 2001, smallpox, when we were, you know, remember the smallpox stuff that came out before the invasion of Iraq and all that kind of
That's
thing.
within that 20 years.
It worked in areas of Africa where they had smallpox up until the 70s and stuff like that. But there was smallpox vaccination, but it was very effective. And it's actually very effective against really, especially the aerosolized ones, where it's much more, like measles is so contagious, it's unbelievable. And so, you know, and there are people now who aren't getting measles vaccines. That's a different discussion, but quarantine works for those kind of things. So as a general tool, for particularly for the highest reproductive rates of these organisms, it's very effective. But like in Africa, it's a really tough thing because even to track the people is now, when you get to these numbers, just not enough structure, you know, infrastructure to really do that effectively. And there's legal issues, of course, enforcing this.
Which leads me to a question I would like to ask, the privilege of the moderator. Since we are a law school, I'm curious about the legal issues in one particular regard, and that is reacting to Scott's comment that when it really matters, the decisions get made by the medical and public health experts and not by the politicians. And my understanding of the power structure in this country is that the buck stops with the governor in the states and with the president at the national level, not at the public health or departments of health. So is Scott right, Jessica, or to what extent is he right? Because it would be comforting, I suppose, if he were. But
I think it's more a matter of who's the governor listening to at the time. And so at the point of a public health emergency, you will see a much greater likelihood that they will defer at that point to public health authorities. It doesn't remove completely governor's authority, for example, to act in a particular way. There are circumstances under which aspects of government, there are different agencies that gain different powers under different circumstances. But you don't jettison it. For example, it doesn't mean that suddenly you're health department director or head of a health agency automatically gets the ability to make all of the decisions. It just has to matter who's really listening and who's driving the bus at any particular time.
And the driving of the bus is governed or determined by an incident command system that is accepted by the government. And incident command has what's referred to as rolling command. So whoever is the most appropriate to be in charge at that time is the group that's in charge. So for an epidemic, public health is the incident commander. For a violent terrorism threat, the police department or the police leadership are the incident commanders. For a toxic spill, the fire departments are the incident commanders. And that's what I mean about the emergency situation with the expert person most qualified to be in charge, being in charge. The governor would have to come to the EOC, the Emergency Operations Center, and countermand the command, and that just doesn't happen. What does happen is that politicians shoot their mouth off. So in H1N1, there was a very famous comment by our famous favorite loose cannon, Joe Biden, where he was reassuring everybody that H1N1 wasn't really a threat. But as most of you know, Biden traveled by train from his home to his job and asked, was he planning on doing that? Oh, no, I'm not doing that. So again, the mixed message that you shouldn't be afraid, but I'm not taking the train.
maybe one last question and then we have to stop.
Yes, can you give us a layman's description of what happens in the human body once Ebola, the patient contracts Ebola, and right till death, and how long it takes?
Once you start developing the high fever, like a 6 days or something, if you're going to die, you generally die within 3 to 4 days after that. And there seems to be some people who recover. Let's say if you can give equivalent supportive care to it, it seems like some people really seem to be, you develop the overwhelming infection, and then you get this, so to speak, cytokine storm, and all these different molecules that increase fever, increase vascular permeability, just pour out. It's like a shock thing. It's like similar to bacterial sepsis. And a lot of these people, like in Africa in particular, they're all treated with broad spectrum antibiotics. They're all given anti-malarials because you just throw the kitchen sink at them, because with the leaky bowel, there's probably a lot of bacteria that gain access to the blood and you get bacteremia on top of that. So it's a shock syndrome with
Right, the same principle that I started out with is true of the body too. It first is an under response and then has an over response, and it often is the body's response to the infection.
It's the body's response to it leads to death, but it's also needed to eliminate the infection, which is dysregulated.
Right.
Well, thank you very much to our speakers. Thank you, everyone.